Welcome to the Practicing Clinicians Exchange podcast series on exploring new options in managing the pain crisis of sickle cell disease. This is the second of two podcast episodes in the series titled What's New in Sickle Cell Disease in Vaso-occlusive episodes, and will focus on novel and emerging treatments for managing pain crises in sickle cell disease. My name is Alison Towerman, and I'm a nurse practitioner in the Department of Pediatrics at Washington University School of Medicine in St. Louis, Missouri. I will be your moderator for today's episode. Joining us today is Dr. Michael DeBaun, Director of Vanderbilt-Meharry Center of Excellence in Sickle Cell Disease and Professor of Pediatrics and Medicine at Vanderbilt University School of Medicine in Nashville, Tennessee. This program is supported by an educational grant from Novartis. This program is provided by Practicing Clinicians Exchange for 0.25 ANCC and 0.25 AAPA credits, with 0.25 credits applicable for pharmacology credit for NPs. To receive credit for this program, go to pce.is/sickle. Learning objectives for this podcast are to identify novel and emerging strategies for management of sickle cell disease and vaso-occlusive pain, and list factors to consider in the selection of therapy for sickle cell. Dr. DeBaun, at your institution, how are you currently managing acute and chronic pain episodes in patients with sickle cell disease?
Right. So thank you for that introduction. I'm glad to be here with you today. So we have two basic approaches in the management of vaso-occlusive pain episode. The first is to identify what the triggers may have been for the pain episode. We have a pre-existing relationship with the patients, and so this allows us to understand what the stressors are, often remind them what the previous stressors are for the vaso-occlusive pain, be it excessive exercise, dehydration, or even depression, and to see if we can mitigate those factors that may have initiated their vaso-occlusive pain. We ask them about their comfort measures that they've taken that are non-medicinal that may attenuate the severity of the pain. Then once they're in the hospital or they're in the outpatient setting or emergency room, we ask them if they're able to drink. If so, then we try to make sure that they drink a sufficient amount of fluid so that they can become euvolemic. Obviously, if they're hypovolemic, we will consider giving them intravenous fluids, typically normal saline, just to get them to a euvolemic state. As you know, patients with sickle cell disease have hypostenuria, inability to concentrate their urine. And so when they're in pain, they often will become dehydrated faster than individuals without sickle cell disease. After we assess their hydration status, we will start them on opioids. Typically, we follow their pain action plan if they have not. And so we'll start off with hydrocodone. And if that has not been used or has been used and is not effective, we will go to IV administration of a morphine derivative. We give an initial dose in the ED and reassess in 20 minutes to 30 minutes to wait for the peak onset of the drug to have its effect. And then we give them additional pain medication if their pain is not relieved. In some situations, after we get the CBC back, we'll notice that the hemoglobin is at least 2 grams below their baseline or approximately 5 grams below. It could be 5.5 or 6. And then we will have a discussion about the added value of performing a blood transfusion therapy in that setting. This will be based on a number of factors, including looking at the reticular cell count, if the reticular cell count is low, if they have an oxygen requirement, tachypnea, elevated heart rate, indicating hemodynamic instability associated with low hemoglobin, then we will initiate a transfusion. In the setting of a decreased hemoglobin and pain, we'll also assess for splenic and hepatic sequestration, which can occur in patients, and it's quite subtle because many of the children and adolescents are on hydroxyurea. The spleen can actually maintain its viability and often become a occult site for acute drop in hemoglobin levels. The second approach is how do we prevent the pain events from occurring? And so typically we have these conversations when the patient's not in pain. And so it's not at the time that they're in the emergency room or they're in the hospital and we start with this barrage of strategies to decrease their vaso-occlusive pain rate. We talk to them specifically about their triggers and see if we can mitigate the triggers for their pain. And we also talk about pharmacologic agents that have been approved by the FDA to decrease the rate of pain.
So what are the treatment options for patients with hemoglobin SS disease?
Right. So the mainstay of treatment for children and adults with hemoglobin SS is actually hydroxyurea. It's a drug that has now been used for over 2.5 decades. It is an effective drug in decreasing the rate of acute vaso-occlusive pain, the rate of hospitalizations associated with acute vaso-occlusive pain. It's also associated with decreasing the rate of acute chest syndrome, a life-threatening complication in children and adults with sickle cell disease. It also decreases the number of transfusions that a patient will receive. Roughly in each one of these categories, pain associated with hospitalization, acute chest syndrome, and transfusions, it's about a 50% relative risk reduction. And then there's additional evidence that hydroxyurea in patients with sickle cell disease, particularly adults, improves their overall survival. Although no randomized controlled trial has been conducted to demonstrate the survival benefit, large observational studies across large populations have indicated that this, in fact, is an added advantage. And then for children with sickle cell anemia, hydroxyurea lowers their transcranial Doppler measurement, which also decreases the rate of stroke. And then last but not least, there's evidence that if you put a patient on hydroxyurea, you improve their cognitive function, in part because you improve their hemoglobin level and you improve their oxygen saturation, which improves the oxygen delivery to the brain. That's our first drug of choice for patients with SS. For the adolescent 16 or over, or the adult with hemoglobin SS, or even any other type of sickle cell disease, we will consider crizanlizumab as our next drug of choice, and primarily because the treatment effect is 50%. In the randomized controlled trial, actually, the evidence clearly demonstrated that the patients who received crizanlizumab had a 50% drop in their vaso-occlusive pain rate. And for most families, that's a dramatic decrease in coming to the hospital and a big improvement in the quality of life. So you have both the hard evidence that this improves the decreases of pain episodes, as well as some of the softer evidence around improvement in quality of life because you're not coming to the hospital very much.
Okay, and how about treatment options for patients that don't have hemoglobin SS? They have other types like hemoglobin SC or S beta plus thalassemia.
Depends on the age. For children and adults with SC and S beta thal plus, again, we would offer crizanlizumab as the first choice. We would also offer L-glutamine. The FDA has approved 2 additional therapies for the treatment of vaso-occlusive pain, in part because hydroxyurea was specifically developed for individuals with hemoglobin SS and hemoglobin S beta thal 0, which is about 2/3 of the patient population of individuals with sickle cell disease. And B, hydroxyurea is not perfect. There are some patients who can't actually take hydroxyurea, and then there are others who, when they take it, they actually have challenges if they want to become pregnant, or for men, there are challenges in terms of decreasing the sperm count. And so the first drug that was approved to treat vaso-occlusive pain episodes after hydroxyurea was actually L-glutamine, and it was developed specifically to decrease the rate of vaso-occlusive pain episodes. Results from a randomized, double-blind, placebo-controlled, multi-center phase 3 trial in 230 individuals with sickle cell disease, that's hemoglobin SS, SC, S beta thal plus, and S beta thal 0, between the ages of 5 and 58 years, who had at least 2 pain episodes within the previous 12 months. The results showed that L-glutamine significantly reduced the rate of vaso-occlusive episodes when compared to placebo. Results also demonstrated there were significantly fewer hospitalizations when compared to placebo, and there were more patients in the L-glutamine group who had low-grade nausea, chest pain, musculoskeletal pain, and fatigue than when compared to the placebo, indicating that there were side effects that occurred more frequently in the treatment group than actually in the placebo group. The FDA looked at this phase 3 trial, and based on these results, they approved L-glutamine twice a day, which is a powder that has to be mixed in a liquid to reduce the acute complications of sickle cell disease in adults and children with sickle cell disease at least 5 years of age.
You touched on crizanlizumab. Can you speak to a little more about recent improvements to the standard of care?
The drug was developed based on the pathophysiology that, as we mentioned earlier, the red blood cells of sickle cells actually have increased adherence to the endothelium, which results in ischemia to the organs and vaso-occlusive pain episodes. This ischemia is in part related to expression of p-selectin. And so crizanlizumab is an antibody to p-selectin that decreases the adhesion of red blood cells and white blood cells to the endothelium. And this results in a decrease in the rate of vaso-occlusive pain episodes by approximately 50%. So the main indication for this drug is adolescents who are at least 16 years of age or older. And again, this is sickle cell disease, so it's not specific for individuals with sickle cell anemia. And initially, they're given 2.5 or 5 milligrams per kilogram of crizanlizumab intravenously, and the results were superior with the 5 milligram dose. And they has now become approved therapy for treatment in this population. A trial that is in the field is addressing a younger age group, 12 to 18 years of age, for crizanlizumab, and that will be intravenous on day 1, week 1, week 3, and day 1, and then every month for up to 2 years.
Okay, thank you, Dr. DeBaun. I just also like to say that I think, the key takeaway here is the ability to offer alternative treatment options to patients who may not have responded well to the few therapies that we've had historically. So I think the hope for the future afforded by these options is just really exciting and a step in the right direction for these patients. But that concludes this podcast. So thank you so much for listening today. Remember to visit pce.is/sickle to take the post test and claim your credit for this activity. We hope you enjoyed this podcast, and if you have not already listened to our first podcast in this series titled Current Understanding of Sickle Cell Disease, we invite you to do so by also going to pce.is/sickle.